Okay, so just to resume, I was just checking my login and so on. So I think most people will be looking at this as a recording form. So I'll just kind of talk through a little bit about me, and just to say that there will be some interactive sections. We really learn in the body by doing and feeling rather than just listening and sort of processing things cognitively. So I'm hoping that when we get to that section a bit later on, you'll be willing to join in and have a go at a few things. And obviously seeking help from a professional as well. So more one-to-one advice might be pertinent for you, having listened to the talk. But yeah, so welcome. So just to say that I'm passionate about an integrated approach to pelvic floor health. And I've learned a lot from courses, reading, watching YouTube clips, but I've learned most from my own body, when it's gone wrong, and my journey to find ease and functioning. And what I have to share with you this morning is from my training as a women's health physiotherapist, which was 20 years ago. It involved a year of postgrad training. I now practice in the NHS as a community physio. So I'm not working in the specific field of women's health or pelvic physio, but I still have those tools in my toolbox. And I'd estimate that probably 9 out of 10, 90% or so of my patients, of my housebound elderly patients I see in the community, are experiencing some kind of bladder weakness or maybe pelvic floor dysfunction. So they're under the bladder and bowel service, where they get free provision of towels and pads. So it's often also continence problems may well be one of the main reasons that people kind of go or seek care, need care, or go into residential care at some point. So yeah, so I'm glad you're here, because we can learn maybe how to prevent problems, how to help ourselves, and yeah, to improve pelvic health. So I'm just going to share my screen now. Just checking I was recording. Yeah, here we go. Right, super. Okay, so let's put that on the screen. Okay, yeah. Okay, so is your pelvic floor, so I did a workshop last week on the hyperactive or overactive pelvic floor that was focusing a bit more on pelvic pain and ways of sort of calming and reducing activity in an overactive pelvic floor. And this week I'm going to be focusing more on what we can do, or the way we go about improving or enhancing maybe pelvic floor muscles that need a little bit of waking up. So how do you know whether you've got an overactive or an underactive pelvic floor? And the likelihood is that you have a mixture of both. The most likely scenario is that your pelvic floor, your pelvic floor is a bit out of balance. So why does this happen? What might contribute to your pelvic floor becoming out of balance, leading to sort of dysfunction? That might be not quite supporting organs. So the organs might descend, or that below the level of kind of the pelvic floor muscles, or maybe continence problems, leaking of bladder or bowel, maybe wind or even air, vaginally or flatulence. So why might the pelvic floor become dysfunctional? So being human, I kind of think we may still be evolving to be on 2 feet. Because it seems 1 in 3 women and 1 in 12 men will experience a problem at some point in their lives, which is really quite a large number of people, much larger maybe than you might think. Obviously, people maybe don't always share their problems. And interestingly, the average length of time it takes for a woman with pelvic floor dysfunction to present maybe to healthcare is about 7 years. So there's a lot of kind of putting up with things, maybe sharing with friends, and not actually seeking active help. But just because these problems are commonplace doesn't mean to say they're normal. So do encourage you to get the help you need. So different things that might put a strain on the pelvic floor: pregnancy, birth, length of the second stage. So the ideal duration for the pushing stage of labor is said to be about an hour, which is the perfect length of time for everything to slowly kind of stretch, but not sort of tear or become damaged, not the fascia, not the muscles. And so a prolonged period of pushing can have more stretch damage to the pelvic floor, and also a short can have more kind of damage as well. So there's always a slight degree of nerve stretch damage to the pelvic floor. And so we tend to reassure ladies in the early weeks after delivery that it takes about 3 months for that kind of normal level of nerve stretch damage to recover. But obviously people present kind of sooner, and we give them support and advice if their problems persist. So another thing that may predispose you to more problems is having a number of babies, so greater than 4 deliveries. We often see a few more prevalence of problems if you've had tears or cuts in the muscle, episiotomy or cut in the muscle, and this affects the kind of the webbing, if you like, of where the muscles all kind of blend in. So the fascia is kind of the connective tissue webbing, and you'll see that a little later on a picture. So although we can do something about the muscles, we can't always change the fascial kind of position of things. So sometimes surgery is therefore indicated, but the one thing we can do conservatively is see what we can do with pelvic floor exercise and strengthening the pelvic floor. So another thing that predisposes people to pelvic floor problems, this is men as well as women, chronic coughing. So things like asthma, hay fever, coughing, sneezing, those sorts of things. Thank you. Yeah, lovely. Thanks ever so much. That's good, the postman with the delivery. The teenagers under strict orders not to come in. So yes, coughing puts a lot of strain, bearing down strain on the pelvic floor, as does kind of retching as well. So maybe if you have a problem that brings about sickness, then also you will have experienced the challenges of maintaining continence whilst kind of retching. So constipation, so chronically having to strain to empty your bowel, that will also have an effect on causing the pelvic floor to become a little bit kind of lower. So when we sit on the toilet, I tend to talk about the pelvic floor descending down to the basement. It will spring back up to the first floor after finishing, but if you're having to prolong that length of time sitting on the toilet, and in fact, I discourage my teenagers from spending too much time, and myself, getting carried away on your phone, maybe in the toilet, and sitting longer than you need to, because that will have just a slow kind of stretching effect to the pelvic floor. I'll talk a little bit later about the optimal position for emptying the bowel fully and quickly, in the ideal way to empty the bowel completely. So another predisposing factor to pelvic floor problems could be connective tissue disorders. So that's we tend to often speak or simplify in terms of collagen, the amount of kind of stretchiness within your tissues. So that's not just your muscles and ligaments, but also your skin, the fascia, and we're all on a spectrum of kind of stretchiness there. And some people with connective tissue disorders just have more fragile kind of connective tissue that is just much more sort of stretchy. So they tend to present with more pelvic floor dysfunction. Pelvic floor muscle strengthening can still improve things, So it's always worth going down the conservative route before maybe contemplating or discussing surgery. And in fact, the NICE guidelines, the National Institute of Clinical Excellence, in their guidelines, they want all women to undergo 3 to 6 months of conservative therapy before surgery. So other things that can cause pelvic floors to become dysfunctional, so nerve damage. This might be to your peripheral nerves. So as I suggested earlier, with regard to sort of delivery, the nerves are stretched kind of in the vicinity, or maybe central nervous system problems such as MS, Parkinson's disease. They can affect not only your pelvic floor muscles and alter the tone in the muscles, but can also affect your bladder and how the reflexes and how the bladder also functions. So that's a little more complex, maybe not for this talk. So aging, that can also affects both your bladder and your pelvic floor. So the normal composition of your pelvic floor muscles is that there's about 80% of slow twitch or postural muscle fiber within them, and about 20% of what we call phasic or fast twitch muscle fiber. Now, with aging, we tend to reduce more of the sort of phasic muscle fibers. So doing some sort of quicker and stronger squeezes with the pelvic floor will help to kind of restore the muscles back to maybe a more normal balance. And with regard to the bladder kind of function can change with age as well. Here comes Katie. So the other thing is smoking. Hi, Katie. There are estrogen receptors within the pelvic floor, so nicotine can reduce the beneficial hormonal effect to the pelvic floor, because the nicotine blocks those estrogen receptors. And then finally, gaining weight. Obviously, your pelvic floor underneath has to support the weight of the body, and so gaining weight can also put a strain on the pelvic floor. So I also wanted to think about, does your mental regulation affect your tension patterns, your posture? So that was one of the things I didn't actually have here as factors that might bring about pelvic floor dysfunction, but your posture can as well. So this is just an image here of a dog. I've used this slide in my last talk. You might be able to see this dog doesn't look particularly happy. Kind of maybe, I don't think that tail will be wagging. The tail is a little bit tucked under. I don't think the dog likes water. So there's a little tucked under kind of presentation there. And I was just going to share with you, here we go, how that might affect the muscle. So postures that hinder kind of normal diaphragm excursion is this kind of sort of tail tuck, this kind of protective position. So when we're not holding ourselves optimally, there may be global tension patterns in our body, for example, a little tail tuck. It causes an imbalance within the body, within the breath, and the breath and the pelvic floor are kind of integral. So, for example, a more sort of tail tucked kind of forward posture. I'll just maybe show you on me. So I'm hobbling around slightly because I've broken my foot. So if you think I'm hobbling slightly, that's why. So a kind of kyphotic posture, kind of head down, tail tuck. This is the kind of posture type that we tend to see women, especially with pelvic floor dysfunction, with prolapse problems and leaking problems. And so we kind of a whole body approach really to improving global mind body is kind of very, very relevant with regard re-educating the pelvic floor. So the reason being, if we do maintain this kind of tail tuck and these kind of closed down, arms folded kind of postures, when we do put an extra strain on the muscles, when we cough, when we sneeze, There's more kind of closed downness at the back half of the pelvic floor, which means that that raise in intra-abdominal pressure bears down more to the front of the pelvic floor, which classically kind of stretches and weakens it with time. So that's often where the defect manifests, with a vaginal prolapse perhaps, which is described as maybe, I'll show you a slide later, that maybe the front wall or the back wall of the vagina not adequately supporting the organs. So that would be the bladder behind the front wall of the vagina, the rectum at the back wall of the vagina. So we often get bulges down maybe below the level of the introitus or the opening to the vagina. Or possibly the uterus may descend. Again, there's ligaments that normally support certainly the uterus in place, but sometimes they can, not be so, fail for whatever reason, and so the uterus might descend, and that's what we term really classically as a prolapse. So the leaking often presents itself, maybe thankfully, urine leaking from the front passage. I have done training also in helping people leaking from the back passage, which obviously is kind of devastating and difficult to manage. So where do we go for help? So I just thought I'd show you this slide. Just spend a moment having a little look at it and see if you can spot a mistake there somewhere. I'm just going to, yes, it will be muted. Okay, so you can probably see at the end there, the National Inpatient Centre. So as I said earlier, a lot of people hold off, maybe seeking help. The average length of time in a study was about 7 years. And so just because it's commonplace, these problems, maybe we speak with our friends, we look online, doesn't mean to say it's normal, and there is lots that can be done. It's just finding the right people to help, getting on the waiting list and so on, and getting seen. Okay, so just coming on now to the analogy that I love, talking about the body and the muscles of the body being a little bit like the instruments of an orchestra. So you can see this black and white image here of an orchestra with a conductor, with all the different sections there, the wind section, maybe the strings, the violins, the first violins, and so on. So an orchestra will know what to do from previous practice, and of course, being led by a conductor that is listening and tweaking things maybe and guiding. So each area or each area of muscles of the body, so we're likening the instruments of an orchestra to the muscles of a body. So each area are fine-tuned and blend with the rest of the orchestra to form a harmonious kind of whole. The muscles know to play at the right volume at just the right time, and be able to kind of stop and switch off when required. And we see this playing out in the body with regard sort of smooth, efficient, comfortable, easy movement. So if one instrument in this orchestra or one muscle in our body is too loud, it might make others around it give up. Or if it isn't loud enough, others might try and make up for it. So to look after your instruments or muscles, you need to notice kind of what they're doing. With regard to the pelvic floor, we haven't got that much sensory awareness to really know what they're doing. So that's why you might seek the help of somebody else maybe to help you and guide you. So with regard pelvic floor, we want to be able to take the pelvic floor muscles, and this follows through to all muscles in the body really, to take all muscles through their full range. So a bit like maybe doing scales, somebody playing an instrument in the orchestra might go through the whole scales, even though all of those notes aren't necessary for that particular part. So we might do some stretching or some full movements, even though they're not part of our normal movement repertoire. And this practice helps guide the muscles to move in the directions they were evolved or designed to move through, and to also rehearse patterns. So habits, though, might be learnt. Other habits might have become learnt and rehearsed. And sometimes these habits are difficult to shift. They're kind of ingrained, and they become familiar to our nervous system, to our conductor, if you like. And it might need to be somebody else who notices as your conductor or your nervous system's kind of almost selectively deaf. And another person, expert, might need to be brought in who's trained to notice the imbalances. So the muscles and patterns of activity that we have in our body are kind of wired together. So what fires together tends to get wired together. We get these sort of shortcut neural pathways, but we can also relearn different pathways. So an analogy of that is me hobbling around in my boot. I'm just going to show you. Here we go. Look, this is what I've got on. It's restricting certain movements, but I've kind of learned quite quickly. I can now walk normal speed because I've learned how to kind of accommodate it with a sort of a plastic nervous system, if you like, that can adapt. So that's just showing you kind of my analogy I like about the body orchestra. So this is a slide looking at pelvic bones. Now this is where I'm going to get you all to have a little feel of where your bones are, and I'll show you on my bones, maybe on the screen here in standing. So feel free to stand up, have a shiggle around. A shiggle is a silly word I made up. It's a cross between a shiver and a wiggle, and it's quite nice to get the blood flowing and kind of try and shake out any patterns of tension that might be fixed and held. So the crest of your pelvis up here at the top, okay, are we call these the iliac crests. And if you trace these down at the front towards the groin, here in your groin on either side is where your hip joint is. So your hip joint isn't actually up here where you sit a child on your hip. It's down to the front, and often people with hip arthritis feel it a little bit more in the groin area. So if you come back up and around to the back, you'll see on the screen, and maybe feel there's a big flat triangular bone that kind of slots your body into your pelvis. It's called the sacrum, and there's two joints either side of the sacrum linking into the pelvis, and these are called the sacroiliac joints. Yeah, so there's a little bit of movement there, but in fact these joints have got kind of, I'm showing you with my knuckles here, a kind of a knobbly kind of surface, so that there's not a great deal of movement, but a few millimeters of movement on each side. So the pelvis isn't a fused ring of bone. There's a bit of movement at the back here, and also here in your pubic area. So if you feel your pubic bone, this is the beauty of Zoom courses. We're not having to sort of feel body parts in public. There's a little cartilaginous kind of joint here at the front of the pubic symphysis. Now, up and underneath here, so if you sort of fold forwards and stick your bum out, you'll feel sort of two knobbly bits at the base of your pelvis, which are your sit bones, or your ischial tuberosities, if you want the posh name for them. Yeah, I call them your sit bones. So they're the bones you sit on, and in fact, your pelvic floor muscles kind of fill that gap underneath the sort of the perineum. And if you feel where your pubic bone is, feel where your tailbone is, you can imagine maybe there's some fibers of the pelvic floor that travel like a sling from front to back. In fact, most of them, or some of them, wrap around the rectum rather than attaching to the bone. It's more like a sling attaching at the front, but just looping around the organs. And if you feel on your sit bones as well, some muscle fibers travel kind of across from right to left, if you like, not front to back, but from right to left on the two sit bones. So your pelvic floor isn't a flat floor, it's more of a sort of funnel shaped area with two openings. And I'm just going to show you now the diagram of the, so that just shows you kind of the funnel shape. So it's not a flat floor. although your pelvic floor is sometimes referred to as the pelvic diaphragm. It is essentially in a similar plane to your breathing muscle, your diaphragm, your main breathing muscle here in the chest. So it's kind of oriented in the same plane. So unlike this funnel, which only has one opening, your pelvic floor has two openings. Oh, I'll show you the female anatomy first of all. So the pelvic floor muscles, this is just kind of one layer, if you like, but I didn't want to go into too much anatomy. There's really no need. Essentially, you can see from this image that we have a kind of a the whiter areas are more the connective tissue or fascia. So the area just in front of the anus, between the front hiatus or opening, the front opening where the urethra and vagina are, we have this area, this white area in this diagram. It's called the perineal body. So it's kind of like fascia supporting and blending into the organs. And the muscles kind of blend in as well. So it sort of blends into the tubes, if you like, the openings. So I'll just show you. So I've written a few notes here. Okay. So the two gaps. So both men and women have two gaps in their pelvic floor. The urogenital hiatus, which is where the urethra and vagina pass in women, and just the urethra in men in that front gap. And then we also have the space at the back, the rectal hiatus, which allows the passage of the anal canal. So between the two gaps, as I said, in men and women, you can see this sort of fibrous perineal body. So the perineum is subdivided by a theoretical line between the ischial tuberosities. So on this diagram, you can see where the white area is the center on the female anatomy there. The muscles that kind of come out to the side attach out onto the sit bones, the ischial tuberosity. So I prefer a more sort of diagrammatic view, if you like, of your pelvic floor for both men and women when I teach exercises. So I like this little diagram here, which shows a diamond shape of the pelvic floor. And what I'd like you to do as you sit there now, obviously fidget and adjust yourselves. You don't have to stay where you are in one place, but just make this shape with your hands. So this is creating a diamond shape where your index fingers would be where the symphysis or the pubic symphysis is, where your thumbs are touching, that kind of represents where your coccyx or tailbone is. And the two bits at the side are where your sit bones are. So essentially, everyone's pelvic floor is roughly a diamond shape with a front triangle to it, the urogenital triangle, and the back triangle or the anal triangle. So basically, yeah, that kind of gives you just a little bit more kind of a simplified version, if you like. It is the muscles in each triangle, especially the front triangle, are a little bit more complex with different fascial layers. And the anal triangle has this strong layer of deep fascia, the perineal membrane between it. So the perineal body, which was that sort of whiter area, which I'll show you here on the male model, there you go. So it forms the junction of the two triangles. It's the middle of the perineum. And in fact, this perineal body does contain skeletal muscle, smooth muscle, which is more kind of like muscle for the internal organs, if you like, and elastic fibers. So as I said, it serves as an attachment point for the muscles. And in women, it acts as a tear-resistant body between the vagina and the external anal sphincter. So with regard to vaginal delivery, there's a little area of kind of almost protection to prevent any tearing of the muscles towards the back passage, that's often when you might get problems with leaking from the back passage. So the nerve that supplies the pelvic floor is called the pudendal nerve. It arises from the nerve root in the body, the sacral nerve root S2, 3, and 4. So, in anatomy at college, I relied on rhymes and things like that to learn my anatomy to get me through the exam. So S2, 3, 4 keeps your bum off the floor, essentially. So the I've got one more image here showing you the episiotomy. So if it looks like somebody during delivery, the muscles are sort of tearing and they're worried about it tearing towards the back, they will perform a mediolateral kind of cut in the muscles to prevent and preserve the more important structures there around the back passage, and they tend to heal really well, but all scar tissue has a little less elasticity in it, so it may be a point of weakness that later on in life, perhaps once hormonal changes have happened and so on, that could be another predisposing factor, if you like, to your pelvic floor becoming dysfunctional. So just going through kind of what helps keep us dry and not leaking when we cough or sneeze. The constriction around the urethra of the urethral wall, and this stabilization, it happens by the pelvic floor muscles during this kind of stressful event. So we don't talk about stress as in it's stressing me out, mental stress. It's more raise in pressure inside the tummy. So the urinary continence mechanism is quite complex and still isn't completely understood. It's based on the coordination of several parts of the pelvic floor. So as a pelvic floor physiotherapist, we're kind of trained to feel and observe an optimal kind of pelvic floor contraction. So I thought I'd show you next this slide, which brings to awareness really the organs that are supported by the pelvic floor. So you can see the white area at the front of the body, B, that would be the pubic symphysis or the pubic bone. Behind that, you have your bladder, your urethra. Behind that, in women, obviously, you have your uterus, and we get sort of retroverted or anteverted. This is a normal retroverted uterus, a normal sort of slight forward tilt to the uterus, and the angle of the vagina, it's not straight up, it's kind of angled back a little, and then behind the uterus and the vagina, we've got the rectum and the anal canal there, and the grey areas illustrate the tailbone, on which the many of the muscles kind of attach. So that's obviously looking at a lady as if cutting in half down the middle there. So you can see also from this slide the angle of the, especially of the anorectum, which is where the rectum forms the anal canal. There's a sling of muscle, the puborectalis muscle, which attaches to the pubic bone and wraps around the back of the rectum. That's why it's called puborectalis. It goes around. That muscle under tension helps to maintain this 80-degree angle of close at the anorectal angle, which is great because it means when we're sitting, standing, things aren't going to start descending out because we're not ready. It's when we sit down on a lower seat, or maybe if we squat, and if we release the pelvic floor down to the basement level, that muscle releases its hold around the anorectal angle, straightens up that angle, and allows things, air, stool, to pass more easily. So I'll do a little demo in a little while of kind of emptying the bowel, which I'm sure you're very excited about. Obviously, I will be keeping myself fully clothed. So this is another slide just showing you what can happen with regard these bulges or defects in the vaginal wall. So this is more like, I mean, it's just obviously a drawing, but it would be more like what we would see on ultrasound scan. So you can see, again, the same orientation. We've got the pubic bone at the front, we've got the bladder behind, the uterus, and then the rectum behind that. But what you might notice here is the slight irregular shape of the bladder and of the rectum, because the front and back wall of the vagina aren't adequately supporting those organs. So there's a little bulge, and maybe in this person, you might expect that they have a little bit more difficulty emptying the bowel completely, maybe, or maybe emptying the bladder completely. So in fact, if somebody were having difficulty with what we call a rectocele or a prolapse wall of the back wall, sometimes people even sort of press over the perineum when they're emptying, change position, maybe even inserting a thumb into the vagina and pressing on the back wall in order to sort of relocate things to the ideal position where things can then pass fully. And it's interesting how, working in my profession, the number of people who have all sorts of different tricks and ways of emptying completely. So you have to be a little comfortable with, obviously I am, otherwise I wouldn't have specialized in it, in hearing how people are coping and guiding them in other ways of coping with emptying completely. But in fact, strengthening the pelvic floor can help to support the organs, but sometimes depending on progressing and the patient's story, it may be that we would direct them for surgical opinion if things aren't getting better, if we can't help them. Okay, so what can we do to help with regard helping pelvic floor dysfunction? So maybe some medication. So after the menopause, or at certain times during a monthly cycle, people might experience a worsening of pelvic floor dysfunction. So the week before and during your period, your estrogen levels drop, and obviously post-menopausally, the estrogen levels drop. And estrogen helps to keep the pelvic floor muscles sort of springy, elastic, bulky, and so on. So say if somebody doesn't want to go on a sort of a more systemic HRT, then vaginal estrogen cream or pessary might be considered, sometimes even in those with a history of having had, say, breast cancer, and that they've been told to avoid estrogen. For some people, because the level of estrogen absorption systemically is so low, it's a case of sort of weighing up with your doctor. I don't prescribe personally, but so decisions are made, and maybe estrogen cream or pessary will help give just a local, very localized boost to the pelvic floor muscles, making them more springy, more elastic, and more supportive for continence as well as organ support. So I'm not touching too much on it in this talk, but there's other problems that we encounter as women's health physios, things like urgency, urge incontinence. So there's other medications that might help optimize bladder activity. And the main one is called anticholinergic medication, which kind of calms the bladder, muscle it down, helping it to remain more kind of in a storage mode rather than kind of twitchy and kind of giving us this sense of sort of urge when it's kind of just got a little bit out of sort of sync. So your physio role, let me just have a time check in here. So so your physio role, I'm focusing on women as I talk to you today, but many women's health physios also treat men. So the subjective history, we spend an hour, at least an hour, often I'd go over an hour and a quarter sometimes with patients on their first visit. I ask them first of all what's a summary of what their problems are, so that I don't then go too, well, I direct my questioning more towards their particular problem. So if somebody uses pads, maybe how many, what type of pads might they use? Some people, although not so many nowadays, but using obviously continence type pads are much better absorbing liquid So sanitary towels are sort of more cotton wool based, great at absorbing blood, but not very good for urine. So I direct people to use a pad that's designed to absorb water or urine, and sort of work out, yes, how many they're on. If maybe they aren't aware, you can be referred to the bladder and bowel service in the NHS and have your pads provided free by the NHS. So the obstetric history, so I'll ask about their birth histories. That often leads people to kind of go into a lovely long story, but that also is very valuable. Hearing the history, how many births, what's been the story at birth, especially the pushing stage of labor. Bladder and bowel emptying, so are there any problems? And just to let you know, the range of sort of normal, considered normal for bladder emptying is having a wee about 7 times a day, as well as having an intake of approximately 7 drinks in a day as well. Obviously on a hotter day when you perspire, you drink more, and it's good to go by the color of your urine. Yeah, so you want kind of that straw-like light colored urine. If the urine's looking darker, then it's a sign maybe that, yeah, you need to be drinking more. And obviously your bowel, if the stool is a little on the hard side or lumpy, and I've just got this lovely illustration here, hopefully you can see this is the Bristol form stool scale, Bristol stool chart. And so, yes, we show people and get them to identify what their normal stool is like. And from that, we might make some suggestions with regard to their fluid intake. And also maybe if we thought they had a slower kind of transit in their bowel, we might suggest a way that they can test the transit time. So the normal bowel emptying, going back to the bladder, it's normal perhaps as we get older, certainly perhaps postmenopausally, or for older men when their prostate gland enlarges slightly, for people to get up once at night. But maybe more than that is considered a little abnormal, and we can look at, if necessary, get them to do a fluid volume chart to kind of identify whether there's any tweaks to be made in the number of drinks they're having in a day, or maybe retrain the bladder to empty a little less, or to try and hold off a little. But that's, yeah, I'll talk you through a few urge suppression techniques, maybe a little bit later. So the range of normal with regard to bowel emptying, so it's normal to empty anything between 4 times a day and once every 4 days. So what is your normal pattern? Has there been any change recently in your bowel emptying? Do you empty completely, for example? So with regard to the bladder, do you sit or do you hover? The pelvic floor muscles don't relax if you hover. So we always encourage everyone to sit on the toilet, and maybe now we've all got alcohol gel on us, I sometimes suggest if somebody says, oh, well, I'm not sitting in a public toilet, you might get a little bit of alcohol gel on a bit of toilet paper, give the toilet seat a little wipe just to allow you to sit and know that your pelvic floor is fully relaxed when you empty your bladder, even in a public toilet. So with regard, yeah, so the wiping clean, that might suggest maybe that there's a little bit of, sometimes people have problems with sort of skin tags, that sort of thing around the back passage. If there's had a history of hemorrhoids, it's difficult to wipe clean. Very, very delicate mucosa around the back passage and around the front. So we might suggest using sort of unperfumed moist wipes. Maybe if people have got problems with leaking, they'd use a special type of barrier type cream to protect the delicate skin, both around the front and the back. We'd ask questions about any pain. Is there pain on intercourse? If so, is it on penetration? Is it on sort of deeper penetration, or is it more on the outside of the opening of the vagina? And yeah, so based on the answers, we might explore with more questions. If you have pain, maybe is it like a dragging sensation that gets worse towards the end of the day? That would suggest maybe a vaginal prolapse or a defect in the wall of the vagina, because the muscles get tired as the day goes on and you get that aching sort of dragging discomfort towards the end of the day. So then the objective part, which is kind of what we observe, and I'm observing my patients even when they're sitting in the waiting room. What posture are they sitting in? How do they walk in? And also what postures, do they hold, and ask questions really about what their activity levels are and movement patterns are. But with regard the objective part of the examination, we invite ladies to have, if they're comfortable, to have a vaginal examination. This is obviously done with consent and a chaperone if the patient wishes. So I have had some patients who say, well, I can only feel it myself if I'm in this position. So sometimes we have patients showing us in different positions, not just the classic sort of laying on your back with your knees bent up, knees open, obviously, but also maybe sitting up so that they can, you can feel maybe what they're feeling more in a sort of more functional, everyday position, because obviously we only get a little snapshot of the pelvic floor and the organ position in that orientation to gravity. But we can learn an awful lot from the examination. And obviously we are put on gloves, latex-free gloves, check that nobody's got any sensitivity to that, use a water-based lubricant or gel, and then insert a finger into the vagina and sweep around on each wall of the vagina to assess the sensation. Does it feel the same on each side? And also we're feeling for the bulk of the muscles, any areas that are tender. And also then encourage somebody maybe to bed down or have a little gentle cough. We've got protection on the bed so that if a little leak does happen, that's absolutely fine. I didn't also mention, but prior to examination, we obviously invite ladies to get comfortable and empty their bladder before as well. So we can learn an awful lot. And although maybe we think, oh no, this is really embarrassing, humiliating, as a women's health physio, your women's health physio will have done this as part of her training with other physios, likely examined each other in order to learn how it feels, not just to feel defects and observe defects, but how it feels to be the patient as well. So hopefully you get a very sort of sensitive and maybe slightly different experience with a women's health physio than you might say with a doctor or even a nurse doing a smear test, for example. Interestingly, in my local GP surgery, I did go and I did do a little talk with the practice nurses to see whether they would be happy whilst they were doing pelvic, doing smear tests or maybe vaginal swabs, just to, whilst patients were there, have the opportunity for some health education and teach pelvic floor contraction. So maybe things like that are going on in other places in the UK as well, or in the world. Okay, so with regard to treatment, so obviously it all depends on what the findings are, and it's kind of beyond the scope really of this talk to go through what all the different problems are. I'm hoping that I may be touching on any issues that you may have, so the main part really of building a relationship with your patient is on education, building up a nice rapport, telling them how things work, what can go wrong, explaining maybe the prevalence of how commonplace things are to go wrong, congratulating them maybe for seeking help, and to say, they're on the start of a journey to try and help themselves. So yeah, so I kind of, try and keep it really sort of upbeat, obviously. So from careful evaluation from examination findings, I'll teach whilst doing an examination optimal pelvic floor release, letting go if there's any holding tension patterns, as well as contracting the pelvic floor fully and as fully as they can. So quite often, interestingly, there's a prevalence of depression, obviously stress if you're managing leaking or chronic pain and discomfort. So maybe discuss that with the patient. Maybe are they doing some form of gentle cardiovascular therapeutic exercise. If not, maybe encourage them to, even if it means that they're leaking, still encourage a little bit of kind of that kind of cardiovascular low level sort of exercise, which will help lift mood as well as start to strengthen pelvic floor as well. But maybe more in a setting that they feel comfortable, obviously that they've got the right pads and that they feel safe to do so. So how to empty the bowels with minimal straining, optimal comfort and efficiency. Okay, so I'll talk you through this now. So basically, I'm a big advocate of using what we call the Squatty Potty step. So basically, I'll just show you now. So please do feel free, stand up, have a shake around, maybe come and yeah, change position. I know the good thing is you're watching or recording, you can pause it kind of as and when you want, and you can have your screen on. But I'm just having got to shake out because I've got a little fix. Oh. So I'm just going to sit here on this chair and demonstrate a few different things, a few different observations. So when we are little and we are children, toilets are designed for adults, so we tend to, as little girls especially, be hovering a little bit, holding onto the toilet, a bit fearful we're going to fall in. And so our pelvic floor isn't terribly relaxed, and our anorectal angle isn't in a good position because we're kind of not supported, so the muscles aren't releasing around that anorectum and allowing it to fully open. Little boys, however, maybe especially sitting on potty, or if they've got some foot support, they tend to lean forward because they're tucking their willy into the front of the toilet, so they tend to naturally learn from a young age a better position for emptying the bowel. So by simply just folding forwards and making the hips more folded, the back of the pelvic floor is a little bit more released and the pelvic floor is starting to kind of descend. So your pelvic floor muscles, interestingly, need to know how to fully release and let go as well as hold on. So that's why it takes time to kind of build up that proper examination and guiding somebody in getting the muscles to be optimally functioning. So the Squatty Potty step, there's a great YouTube clip involving unicorns and all sorts of things. If you Google Squatty Potty step, it is quite entertaining. But basically it's this sort of shape, so it's designed to sort of fit around the base of a toilet, so it can be pushed out the way. Men can still stand with their feet. It's plastic, so it's easy to clean. So you rest your feet on this, which mimics more of a squatting type position, but supported, and this helps to prime the pipe work, if you like, to be in the best open position for easy emptying of the bowel. And then using the diaphragm and the breath, we can optimize descent in the pelvic floor, releasing the pelvic floor to allow things to empty comfortably. So sometimes if we've had a history, maybe of a painful poo when we were younger, we've kind of learned this kind of tension pattern. So sometimes, kind of go into quite a lot of detail with regard releasing the muscles for optimal emptying, and obviously encouraging women to sit, not hover as well. I mentioned that earlier. So with regard to, here we go. The bladder, I mentioned earlier about the bladder diary. So if somebody has got in our findings that they've got, maybe they're visiting the toilet multiple times, the volume that they're passing is a lot less than you see their maximal void, and obviously the largest void is often the one first thing in the morning. So you might then guide them with some re-education of their bladder. So just to think about what the techniques might be of helping to maintain the bladder in what I call storage mode. So as part of my education for the bladder and the organs, how they function. So I normally describe the bladder a bit like a balloon that's normally kind of relaxed. And all the while, the kidneys are drip feeding into the bladder, and gradually the bladder kind of gets a little bit more stretched and full as the balloon distends or the bladder distends. And this all happens with the bladder muscle quiet. So it's kind of relaxed and allowing it to fill more. What happens is we'll often get to a certain level of fullness where we get a little feeling of like, oh, I could do with going to the toilet. And that's when your bladder sort of just starts to sort of twitch at a certain level of distension. But normally we can, if we're busy doing something, we can put off that feeling, and it's not until the bladder slowly drip fills a little bit more, we'll get a more urgent feeling the next time. And it may be then that we then decide, yeah, now I'm going to go and empty. So what can sometimes happen is the cascade of reflexes that switch your bladder from storage mode into empty mode. So when we do decide to empty our bladder, we will sit on the toilet, we fully relax the pelvic floor, which sends a cascade of reflexes to maintain the bladder in emptying mode while it squeezes and empties until the bladder is completely empty. So in days gone by, women were encouraged to do what they called the stop test, which is to stop the flow of urine, maybe halfway through or towards the end of a wee. But what we realized, this is maybe a good 20 odd years ago, although yeah, you still hear that maybe as an exercise sometimes, but what we realized is that by tightening up the pelvic floor against the pelvic floor squeezing, it switches the bladder back into storage mode again. So it would then mean that the bladder doesn't fully empty completely, and can be associated with obviously things like urinary tract infections if the bladder's not emptying completely. So we don't advise that as a regular thing, although I might suggest maybe to people who don't want to have a vaginal examination to do that perhaps as a test of their pelvic floor, just to see if they can either slow down or stop the flow, but very much towards the end of the flow, and to only maybe do that as a test once a week. So this detrusor inhibitory reflex, which basically is a posh word, detrusor is the word for a bladder, it's inhibited by the pelvic floor contracting. We can use this reflex to help with urge suppression, with switching the bladder back to storage mode. However, the grading of how strong we tighten the pelvic floor against the bladder when it's twitching, it's variable in different people. So I often get people to start off with a very gentle contraction, maybe especially if they're triggered, their bladder is triggered by certain things like keying the door or walking into the bathroom or hearing a tap running. Basically trying to sort of distract your attention from that stimulus. Where we see children when they need a wee, what they do is, I'm just going to show you, and you can join in as well if you want, and it's not a bad thing to have a little stand up, but they are sort of doing a little dance on their tippy toes like this, and they're probably holding themselves like this, because what those things both do is it's bringing the calf muscles into activity, which is the same nerve supply as the pelvic floor. The same nerve root that supplies the calf supply the pelvic floor, and the holding of the perineum stimulates this inhibitory reflex. So in children who kind of don't know any better, who are maybe not such with social grace, we might be aware that they need a wee by doing that. So how can we do that, but in a more sort of acceptable way? So we might just rock onto the front of our feet. We might try standing on tiptoes. We might sit down on maybe the arm of a sofa, a sort of a curved surface to provide that pressure to the perineum. If we're at home on our own, obviously we might hold the perineum. Men might pinch the end of their penis. Or we can try engaging the pelvic floor at a gentle level for up to 15 seconds. So it takes about 15 seconds of a gentle, sustained contraction in the pelvic floor to switch the bladder back into storage mode. So it takes practice and perseverance. Okay, so going back to other things with regard urgency. So we'll look at their fluid intake. Are they taking a lot of caffeine? Have they tried weaning off caffeine? Does that make a difference? It's really important to wean off it slowly, because caffeine can give you withdrawal headaches if you just cut it out suddenly. So over a period of about a week even, I suggest people to gradually reduce the amount of caffeine and substitute it for caffeine-free. And something like cranberry juice, that can help. There's something within the skins of the cranberries that prevents the adhering of bacteria to the lining of the bladder. So that can sometimes be useful in helping to keep the bladder healthy. Emptying the bladder completely. So some techniques here of emptying the bladder completely. We call it, we basically can encourage people with their sort of fists coming up above your pubic bone, leaning forwards on the toilet. So this is what to do after you've finished your wee, so especially good for if you've got a little misshaped kind of bladder or less support with maybe areas that aren't emptying completely. By pushing, squashing it and leaning forwards, we get a little bit more pressure to maybe get that last bit out. I often encourage people to wipe a little, but then stand up, jiggle a bit, sit back down, relax fully again. That forward sitting position is also good for bladder emptying. So again, they might find that attempting a second void, a second attempt, at least sort of 15 seconds or so after the last one, because that's how long it takes for the bladder to rest before maybe trying to empty again. They might find that a little bit more empties with that second void. And if you're kind of got a hunch that you're not emptying completely, going for a bladder scan is really good, because they can just check that the bladder is emptying completely. For some people, maybe that for whatever reason, the bladder doesn't empty completely. Maybe the bladder's become overstretched at some time and it's kind of floppy and isn't very good at squeezing and emptying fully. Or maybe they've got problem with the reflexes and the nerve supply to the bladder. It may be that these people are taught to do intermittent self-catheterization, which is a bit tricky, especially for women with a mirror. Everything's maybe a little bit back to front, or but it can be learnt and is important. And there are various specialists who very much guide people, and that's become a lot. There's sort of single-use pre-lubricated catheters that are used and so on, very discreet. You can just empty your bladder with the help of a small catheter into the toilet, and maybe that might be needed to be done possibly a couple of times a day, not necessarily every time that you empty. So the other thing, the various, so with our treatment as pelvic floor physios, we might use other kind of gadgets and things to help people see and learn what to do. So we very much guide with our voice, with tactile cueing, with an examination, but also somebody being able to sort of be fully clothed, feeling less kind of inhibited, I guess. We can use something called EMG biofeedback. In fact, I've got that a bit later on. I'll just talk to you about this. So EMG biofeedback, we use a vaginal or rectal probe, which rests inside either the vagina or the rectum, just on the walls of the pelvic floor, and then projected on a computer, you have a live image of what your pelvic floor muscles are doing. So the electrical activity in the muscle is kind of like a graph, a live graph that's kind of continually kind of going along. And you can see when you tighten up, kind of what happens to that line, when you relax fully, what happens to that line. And it just helps you to reconnect your brain with your bottom. As I hinted at earlier, the sensory nerve supply to your pelvic floor isn't brilliant. And sometimes that's made a little less brilliant with stretching or with age. And so having something like that to guide us in what we're doing can be really useful. Interestingly, the vaginal probe that they use for biofeedback, they also engineered something called the pelvic floor educator. I was trying to find mine desperately this morning and I can't find it. But anyway, it's about £15. It's available on Amazon and various other medical equipment companies. And it's an internal probe with a sort of indicator stick. I'll just show you using my biro. But basically, for women, inserted the probe inside, you end up with this sort of indicator stick that you can look side on. So it's almost like, you can see my pen here, like a little plastic penis. But if you imagine when I tighten up my pelvic floor, the angle of the muscles doing that causes the indicator stick to dip very, very slightly. So what this allows me to sort of see and feel is, oh, okay, I'm doing that correctly. Yeah, so it gives, again, some form of feedback that I can see that might be useful in helping motivate me with exercise or guide me to do the right thing. So that's called the pelvic floor educator. And the piriform probe, the shape of the probe has been really cleverly designed, in fact, by a physiotherapist, to accommodate any lumps or bumps or bulges within the wall of the pelvic floor. Yeah, so hopefully, unlike the old-fashioned pelvic floor weights, these kind of cone or tampon-shaped plastic weights that used to be all the trend, they've gone a little bit out of favor because any bulges within the vaginal wall, which incidentally are quite commonplace. About 80% of women do have a bulge in their vaginal wall without even being aware or symptomatic. So what these bulges do is they sometimes push the probes out or push a tampon out. But this clever shape of the piriform probe, or the pelvic floor indicator stick, the piriform, I think it is called piriform indicator, has been designed to accommodate these bulges so that it doesn't get pushed out. So yes, so anyway, that's an aside, but I'm sorry I've not got one to show you. So the other form of biofeedback that's commonly used, I've had the benefit of doing this with one of my pelvic floor women's health colleagues, is real-time ultrasound scanning. So this is done through the perineum. So again, does involve getting undressed. A lot of that sort of ultrasound gel, so they can get a good image of what's above inside. And when you do a pelvic floor contraction, the bladder neck kind of moves, yeah, and it can be visualized on a screen. And the support of the urethra involves both voluntary muscle and fascia, yeah. So I just wanted to make you aware that having a really strong pelvic floor might not necessarily preclude you from having problems either with leaking or with prolapse. So it could be, if there's fascial sort of defects, the muscles can be strong, couldn't get any stronger, but there's still a problem there. So in an individual with a firm supportive layer, so in sort of an ideal scenario with this firm supported layer, the urethra is compressed between the abdominal pressure. So when we cough or whatever, that causes the urethra to sort of move, and the pelvic fascia. So the urethra is compressed between the pressure inside and the fascia in much the same way that the flow of water through a garden hose is stopped by stepping on it and compressing it against the firm ground. So if the layer under the urethra becomes unstable, maybe somebody's got a connective tissue problem or extra stretchiness, or have got scar tissue or a defect, what happens is the opposing force that causes closure is lost, and the occlusion or the stopping of the flow is diminished. So this analogy is as if trying to stop the flow of water through a garden hose resting on soft soil. Yeah. So yeah, I've mentioned about the piriform probe, the pelvic floor educator, and this is just another cross section, a more diagrammatic version showing you the pelvic floor, actually the other way around. So we've got the pubic symphysis, PS, there at the front. you can kind of make out that loop of muscle, the puborectalis muscle, looping around towards the back of the pelvic floor, the tailbone there, just loops around the rectum, and there's some attachments there onto the coccyx, the tailbone. So some down training methods. So last week I focused very much my course on reducing and releasing tension in the pelvic floor. There's an amazing physio called Maeve Whelan. She is from Ireland. She has the most beautiful Irish voice as well to listen to on her website. But she has a nice series of pelvic floor leaflets encouraging the down training methods, the sniff, flop and drop technique. And this can also be used in conjunction maybe with some EMG biofeedback, or I tend to get people to really quietly persevere and practice the sniffing, allowing the belly to flop and the pelvic floor to drop. And that's what I thought I'd do with you now. So you can, if you'd like, get into side lying or say stay sitting if you would like. And I'll talk you through the very important correlation between the breath, the diaphragm, and the pelvic floor in helping to make sure the muscles are optimally kind of releasing. And even a pelvic floor prescription, in between each pelvic floor contraction, we would encourage you to release fully at the end and repeat this practice of a gentle sniff, allowing the belly to flop and the pelvic floor to drop. So I'm just going to talk to you a little bit more about the diaphragm. So for the purpose of releasing the pelvic floor, we want to make the diaphragm, the breathing muscle, descend. So we want the diaphragm muscle to kind of descend as the breath comes in. When we know that the diaphragm is maximally descending, we get a sense of the lateral, the rib cage out here at the sides moving outwards. And what we don't want to feel is the chest lifting. We want to see if we can practice now as you take a very gentle, slow sniff of air in. We want to try and keep the chest down. So maybe rest your hand here on your breastbone. As the diaphragm kind of descends, we maybe sense a soft tummy and the ribs expanding out kind of laterally. So a key part of this is that it must not be forced and the stomach must stay completely soft. Now, doing this sitting is the most challenging position. I sometimes think laying inside lying. So maybe at nighttime, this is a great time to practice. When you're comfortable in bed, you might even pop a pillow between your knees so that your pelvis is nicely kind of relaxed and comfortable, you're nicely aligned. So just to suggest that this breath in should be through the nose. It should be very gentle, very slow, maybe slightly audible, as if a gentle sniff of air in, indicating that there's sufficient volume of air to make the diaphragm descend. This slow breath in wants to be sustained for at least kind of 3 seconds, allowing time for maximal release. In contrast, the breath out is a more sort of passive kind of recoil. So it's kind of just happens really on its own. So the breath out kind of just happens on its own. So the pelvic floor release happens on the in-breath, and it goes in conjunction with what we call the flop, or the tummy flopping and relaxing. So we could try this now, maybe in sitting. I know that my remit was to encourage and do sort of sitting-based exercises, but I think I'm going to get down onto the floor and practice this abdominal release, because I'm on a journey with everyone else to learn to sort of release the belly, get the diaphragm descending a little bit better, and get that maximal release of the pelvic floor, in order then for my pelvic floor muscles to be able to come back to function when I need them. Yeah, so they need to learn to switch off, to stop, to drop in order then to be able to fire up when needed. So lying down, maybe on your back or on your side, feel free to join in with your knees bent if you'd like. Both hands are placed on the upper tummy at the level of where the ribs kind of form a triangle up into the sternal bone. So you can maybe rest your hands here. And as you sniff inwards, the diaphragm descends and the stomach fills up into the fingertips, or it kind of flops out. So the stomach should importantly be soft as it flops out. So a good way is to check as you're doing it, press into your tummy. Does your tummy stay soft? In fact, I'm not going to lay down because I can't demonstrate. Does your tummy stay soft as you let that breath of air come in? So keep pressing your tummy, ensuring that you've the tummy, you've sniffed and pressed into the tummy again, maybe checking that it stayed completely soft throughout that kind of 3-second inhale. And you stay with the stomach filled out, if possible, for a few seconds, and then let the breath just fall away. So you have to be careful, because if a forced breath in, or if it's performed incorrectly, the flop will result in stomach tension instead of a soft release. So there's very much a correlation between the fascia in the tummy and the fascia of the pelvic floor. So we can maybe feel what goes in our tummy to sense a little bit more what goes on in our pelvic floor, which may be less on our radar, less sensory awareness there. So remember, it is the upper stomach you should concentrate on mostly. And you should not flatten the upper stomach in order to fill up the lower stomach, but rather fill up the upper stomach, and the lower stomach will automatically fill. So maybe try that again. Press with your hands in your upper belly. Maybe you're laying on your side. Maybe you're laying on your back with your knees bent up. Maybe you're sitting. But just add in that sort of gentle, slow sniff of air in, trying to keep the chest quiet, the lateral ribs widening, expanding, and this gentle feeling of upper belly filling, and then lower stomach kind of following. So that's gone through the sniff and the flop, and then the drop part. It kind of all happens together, the sniff, flop, and drop. But Maeve Whelan on this pelvicphysiotherapy.com website has leaflets and guides you in it. So the pelvic floor should be held up just a little from its fully extended state in order to support the organs and the pelvis. So this is normal. So as I was saying earlier about the pelvic floor kind of being held at the first floor level, it can descend to the basement as it drops, so that we'd expect the pelvic floor to drop and release when emptying the bowel. So it should be easily possible to let the muscles go to a fully released and lengthened state. And if this is not possible, then the pelvic floor might be held in a hyperactive or overactive state, even at rest. So this can become problematic and even painful over time. And maybe you need someone with more guidance, with maybe some biofeedback, with examining you to sort of check what you're doing. So the drop part of the pelvic floor. So again, I don't know, to feel the pelvic floor, I found this best myself practicing inside lying, because you haven't got gravity kind of down on your belly, which is sort of counterintuitive to your belly expanding, but side lying allows the organs just to rest. So you maybe lie on your side with your knees bent, and you make an image of your pelvic floor. So you might do the image of the sort of diamond shape, and thinking of that diamond shape sort of gently releasing down. So what you do is you think of the muscles around the back passage, and also around the front as well. But we often feel the drop a little bit more in that back triangle, the coccyx, the back triangle of the pelvic floor. So you make sure your stomach is completely soft by pressing it maybe, and that you're not pushing your pelvic floor down or pushing your stomach out. Instead, it happens automatically with the breath, with the sniff of air in. So with a gentle sniff of air in, you keep the tummy soft, the ribs expand out to the side, the upper belly, the lower belly fell, and then you get this corresponding drop and feeling of releasing, opening the sit bones, releasing apart, maybe the tailbone moving away from the anus, yeah, the back passage. So the back passage and coccyx bone sort of release a little bit wider away. So remember, it can be impossible to feel at first. It takes practice, quiet time, slowly, patience in observing this important, really important component of pelvic floor activity, which comes before the strengthening part. It's the sniff, flop, and drop. So the perception of the movement and the range of movement improves when the sniff, flop, and drop are used all together at the same time, bringing it kind of all together. So if you're aware that your diaphragm is kind of held or you're breathing shallowly, the chances are your pelvic floor is a little bit stuck and fixed in that position as well. So that's why, as part of a kind of an integrated approach to pelvic floor health, I really love yoga, Pilates, and obviously I teach Pilates-based exercise class, which incorporates the breath and the movement together to heighten that body wisdom and awareness of the breath and the body, and also the breath and the mind. So the breath out is really calming and soothing, and calms the nervous system, regulates it to a nice, easy level as well. So I'm going to talk to you a bit more about pelvic floor and engaging it maximally. So there's a physio called Carrie Boe. She's a Norwegian physio. She's done quite a lot of research in exercise prescriptions. You still see a huge variety of different exercise prescriptions online. There is really no consensus, but why I like this particular physio's prescription is because it's doable in my mind. It's also simple, and it's been proven with CT scans and MRIs in her studies to look at the pelvic floor muscle bulk and the amount of space that organs can descend kind of reduces. So what she found after her exercise prescription, after 3 to 6 months of doing this exercise prescription, was that the muscles became more bulky, bigger. In other words, they hypertrophied, they get bigger as they do with any maximal exercise, and the amount of space for organs to descend, the hiatus or space, reduced. So there was less likelihood and more support to the organs as well. So her exercise prescription is to work the pelvic floor maximally, both around the front triangle and the back triangle, and to fully release between each one is kind of a bit that I've added in, because since her studies, we've learned the importance of fully releasing as well as fully contracting. So basically, you could try in different positions. One of my friends who has kind of had a little traumatic history in pelvic floor, she finds doing her pelvic floor exercises laying really kind of triggers her. She doesn't like doing it. And in fact, laying is maybe not the best position, because when we lay down, we haven't got gravity on or the organs on top of the pelvic floor. So working in a more functional position like sitting or standing is better. So maybe stand up, because what I want you to do again is to feel the bony points of your pelvic diamond, and it's a lot easier in standing to do that. So maybe have a little shake out, shake your tail out. Yeah, maybe practice in standing this little sniff, flop, and drop. In fact, I'll get you to do that in standing. Another good place to feel what goes on in the drop is to actually feel right over your tailbone at the base, and you can somehow just sense a little bit with this sniff, flop, and drop. If you're quiet and quite tuned in, you sense a slight release, or slight flaring, slight release there around the tailbone as the tailbone releases. So maybe keep the tummy soft. And then you sense without forcing anything, when you just let the diaphragm descend with that gentle sniff, you feel the belly flop, the pelvic floor subtly release and drop. So it's always good to start in that rested sort of base level, basement level. So Carry bow refers to the pelvic floor as having different sort of levels. So I like people to go up to the top floor, or even try visiting what we call the elevator. I don't know why I'm still showing you this shape, but it helps to visualize. So just feel your pubic bone, where the pubic bone is at the front, your tailbone is at the back, your two sit bones are each side, and be aware that there's kind of almost a back and front half to that pelvic diamond. So I get people to start with the stronger back section, the back triangle. So close around your back passage, as though, and you won't see any movement as such, it's just like a subtle feeling of tensing up around the back passage, as if trying to stop wind. Close around the front, as if you're trying to stop the flow of urine. And then think about drawing your sit bones towards each other, closer together, drawing your pubic and tailbone towards each other. So everything goes up and forwards as maximally as you can. And then relax everything and let it go all the way out and release again. So maybe when we're doing a pelvic floor squeeze, we're less aware of the muscles when they're either held up or held in one place. We're more aware of a movement, dynamic movement. So during the time that you think, right, I think I'm at the top floor, I think I'm as far as I can go, you'll feel you can't breathe very fully or widely because your diaphragm and fascia of your belly are all engaged with your pelvic floor. But during that ideal 8-second period of trying to hold it up there at the roof terrace at the top floor, you keep trying to revisit and go as high as you can. So we'll do another one together. So maybe think about releasing first of all. Let's go back to that all-important release. Shake your tail out a little bit. Make sure you're not holding tension there. So you close around your back passage as if stopping passing wind. Closing around the front section as if trying to stop passing water or a wee. Draw your sit bones closer together, pubic and tailbone. Draw everything up as high as you can. Maybe see what happens. What happens if you turn your feet slightly inwards and then relax the pelvic floor and let go. So interestingly, the angle of your feet, maybe hips turned in slightly, affect the distribution of activity in the pelvic floor. So exploring doing pelvic floor exercises in different positions, maybe sitting forwards in the chair, try one there. Try sitting back in the chair, so you slump back. And depending on where you are, either on your feet or on your bottom, if you're sitting, will affect the pelvic floor firing. Yeah, so it's very much posturally related, and so they never have to be boring. You can kind of experiment. Yeah, when we turn our feet a little more out to the side, we get more activity in the back of the pelvic floor. It's ideal to have your feet on straight, and in other movement type practices, whether it's yoga, Pilates, you kind of work on maintaining optimal alignment and also optimal function in all of your joints. So for example, as I said earlier, people come up onto their tippy toes, children do, to prevent pelvic floor, to get maximal support from the pelvic floor to prevent leaking or urge. So when we get older, if we get very stiff around our big toe joints, we're not able to sort of push off and move through our feet. So we get a little imbalance in our pelvic floor just through other areas of the body. You can't just look at the pelvic floor in isolation. And I knew I just wanted to share this with you. So one of the things I've got into over the years have been these sort of barefoot style shoes, which aren't those strange 5-toed shoes, but I'll just show you one now. So this basically, it kind of doesn't have a very thick sole. You can kind of see it's got lots of bend in it, so it's kind of very rubbery, so it allows you really feeling the floor and to really be able to push off. The other shape of the shoe is that I've got quite wide feet, and so it allows my toes to spread out as I push down and push off. So it actually helps keep my pelvic floor in balance, because I'm working through my feet, and feet and pelvic floor have a big kind of correlation. So that's why this more integrated whole body approach to pelvic floor health is better, and kind of a little bit why I've gone away from working just purely as a pelvic floor physio, because you don't expect your physio to kind of look at your feet and ask you questions about your feet, but it all has a big knock-on effect. This is another prop I've just got when I went to get my shoe, which is basically a kind of a visual cue to illustrate what should happen when we move, when we bend, when we squat. So the pelvic floor is designed to expand and release. Yeah, so the soft tissues that support it allow it to bend. So people who maybe have this kyphotic sort of posture or hold a lot of tension around the back of the pelvic floor. So if I'm one of these people that hold a lot of tension here, if I've got a lot on my mind, I tend to be a little in this kind of protective position of tail tuck. When I go to bend, let me just get my screen so you can see me. When I go to bend, I'm much more likely to, let's just check, you can see. So I'm much more likely to bend like this, maintain this tight back triangle of my pelvic floor and bend with my back, rather than the ideal way that I've practiced with my movement practices, which is to fold, soften and fold at the hips and let the bum spread really wide, yeah? And obviously if you're bending down and someone's behind you, you probably would, out of modesty, tuck your tail and bend in a different way, tuck your tail, but it puts a lot of pressure on your lumbar spine. It's not the ideal way, and it's preventing your pelvic floor from fully releasing and opening. So I've got stretchy trousers on, maybe you have as well, as you're expecting to practice. So how is it for you to fold and bend? So sometimes we lose that ability to fully fold at the hips, or maybe we've forgotten these primal movements that we learned as a baby. So we might practice in sitting, so with our bottom supported by bringing yourself forward, supporting your weight on your arms. You're sort of in a little bit of a squat type position. I've still got my Squatty Potty step here, so by resting my feet on something higher, again, I'm modifying it, getting towards a more functional squat. And interestingly, because I've been a bit desk bound with this silly foot mending, my upper back has got a little sort of tight, and you need quite a flexible thoracic spine to be able to squat. So a little bit of restriction in one place hinders something else, and it's kind of a knock-on effect to what our movement choices are in life. So that's why a whole body approach, as well as some targeted pelvic floor exercises, are really key. So yeah, so when we bend, our pelvis spreads and widens. When we straighten, our pelvic floor releases back to its preferred kind of resting position. Okay, so the other thing I did want to do, just to spend the last 20 or so minutes of the course, is some laying exercises. But in fact, to finish off, I would like to talk a little bit about the knack as well. So that pelvic floor prescription, sorry, going back to it, I know we just stood and practiced some together. You can do them standing, laying, side lying. Even when you get proficient at them, do them walking. Ideally, 8 lots of 8-second holds. I don't count to 8 when I do them. I tend to just, I don't know, hold for a little while, keep going back up that roof terrace, keep going up, keep going up, keep going. When I think, oh, I can't hold anymore, right, I'm just going to relax and let go. But allow yourself time to do maybe that sniff, flop and drop, or a slightly modified version of it to release fully before then doing a second contraction. Maybe doing 8 in a row is too much, so you might just space them out a little differently. But if you were to do 8 lots of 8-second holds in a day, 8 lots of 8-second holds 3 times a day, then you would expect in 3 to 6 months to have this change in your muscles, providing more support to the organs and likelihood of an improvement of your problem. So with regard improvement, we expect about 70% of women to improve significantly enough not to warrant maybe surgery, but if you're not sure you're doing the pelvic floor exercises correctly, get somebody to check that you are, because occasionally people could be doing them completely wrong and make things worse rather than better. So the other thing I wanted to talk about is the knack. So the knack is being able to tighten up your pelvic floor muscles before and during a cough or a sneeze. So let's just have a little hypothetical go as you sit or as you stand now. So what I'd like you to do is, without in particular thinking of your pelvic floor, just do a little cough and notice what happens down below in that pelvic diamond. So when I cough, I feel a little kind of descent, a little feeling of everything going oof, like that, yeah? Because the intra-abdominal pressure is raised, and that has an effect kind of on the pelvic floor. So if I need to, I can tighten up my pelvic floor before and during a cough. And what I kind of feel the pressure is not bearing down to the pelvic floor. That area I'm trying to pre-support by pre-engaging, pre-activating the pelvic floor before that cough or sneeze. And it's all very well when you haven't got a lot in your bladder, but sometimes if you're just about to go to the toilet and a cough or a sneeze or you vomit, something like that happens, it's often very, very difficult to control. So just keep that in mind. If you do leak, don't be too surprised, or maybe try not to worry too much about that, because there's a lot of the pelvic floor is having to support. So the other thing is referring on to surgery. So we might refer on to a urogynecologist, a gynecologist, maybe somebody who specializes in fitting these ring pessaries, which are kind of fairly rigid, plasticky sort of rings, I guess, that support the walls of the vagina. So for some people, if they don't want to have pelvic wall surgery, they might have a pessary inserted just to support things ideally where they should do. And they stay in fact, and just get changed. Obviously, if they're not the right fit, or they'll get changed every now and again to check that there's no erosion through the vaginal wall. And quite often, I think if people are using a pessary, I would often suggest that if they can, they would use some form of estrogen therapy, because the walls are a little bit more bulky and more elastic and able to withstand any sort of rubbing or erosion from movement, if that makes sense. Okay, so going back to the body orchestra analogy, optimal functioning of the pelvic floor, because it does work quietly in the background. Just as your neck has been working all the while in supporting the weight of your head, you haven't been aware of it, your pelvic floor is kind of automatically functioning. And the pelvic floor functions best with a full range of movement in a wide repertoire, which as adults, we don't climb trees anymore. We maybe go upstairs one at a time, not two at a time. We don't squat down. We don't have this big repertoire of movement in our daily lives. So we want to optimize the fullest range possible in all areas of the body, and with regard feet as well. So as I was saying about these barefoot shoes, and maybe walking around the house bare feet if that's possible for you. But there is this connection, between feet and pelvic floor. So fixed postures, postural habits. So the remit today was for sitting, which I've kind of talked you through some of those seated exercises. So in fact, let's just do a little bit of practice here in sitting, looking at the pelvic floor. So if you sit with your back against the backrest, you're likely to be in a little bit of posterior tilt or tail tucked under. And if you were to do a pelvic floor squeeze here, you'd feel it more just at the back triangle. And there's not a lot of point strength in the back triangle if you're leaking from the front or you've got prolapse problems. So what we'd like to do is to kind of maybe sit either in the middle or slightly to the front. And again, think about closing around the front passage as though stopping passing water, closing around the back, drawing together the two sit bones, drawing the pubic and tailbone together as if tightening up the skin of a drum, going up as high as you can, and then relaxing everything and letting go. And then you sniff, flop and drop. I'm going to get you to practice here in sitting with a little bit of tactile contact to the to the sacrum or the tail area, the base of the tailbone. And just see if you can quietly encourage, without the chest rising, the belly to stay soft. Don't force the air in, the belly stays soft. And as you sniff, you sort of almost sense the face widening, the sides of the ribs spreading a little wider, and the pelvic floor dropping, releasing. And you might feel with your back hand here, the pelvic, the tailbone very subtly releasing backwards, or maybe a feeling of descent there in the pelvic floor. So maybe if you do sit for a long period of time, or maybe you might be even, or need to be in a wheelchair, you can still, if possible, move your pelvis backwards, forwards, even circle your pelvis into the chair. So you kind of side on here. So we might go all the way around here and see how that feels. I've got a gym ball over there. Sitting on a gym ball, if that's possible for you, is good. It allows more dynamic movement. Another little pelvic floor kind of releasing exploration is to sit side on your chair. So hopefully if you're on a chair, or find yourself a chair that doesn't have an arm, so you can sit side on, and then you can hold on to the back of the chair. And I've got one sit bone on the very edge of the chair here, but the other sit bone, the other half of my bottom, is hanging off of the chair. What I'm now going to do is to let that side of my sit bone drop down and then lift it up again. So I sink it down and I lift it up. And I'm using my foot here to help me a little bit, but I'm just letting the waist on that side lengthen and then close down. As this side of my waist spreads open, this side closes down. So there's this reciprocal action, this orchestra of activity going on, one side closing, the other side opening. And then I'm going to take a rest. I'm just going to adjust myself slightly because it's a little bit hard on the edge of my chair for that sit bone. And then on the same side that I've done that dropping and lifting, I'm now going to do a little circling pattern. So I've got one side on the chair, the other side off, and I'm just circling around and just bringing about a little bit of movement, fixing one half of the pelvis, but moving the other. Can you circle the other way around as well? Again, I'm using my arm to help. I'm holding onto the chair so I don't fall off. And then take a rest and come back to sit square on your chair again. Have a fidget of your bottom. Always trying to fidget your sit bones maybe a little bit wider apart so that you're not getting into that pattern of tail tuck and closed around the back triangle. So trying to release around the back often restores a balance to the pelvic floor that's key to restoring normal, healthy functioning and pelvic floor contraction. So trying closing and tightening up again around the pelvic floor muscles. Does it feel any different? Do you have a heightened awareness of that diamond? Maybe you sense a slightly more heightened sense of that half of the diamond. That for me, it's my right half. Yeah, maybe not. So we've got the other side to do. So I'll do that with you now. So just pop yourself side on with the other half of your pelvis or sit bone hanging off the chair. Just adjust yourself. Make sure you're not kind of on too hard an edge, or you're not sort of squashing all the soft bits down below. But let's drop one side, drop this side as if you're dipping your sit bone into a pool of water and then lifting it back up and out. So just doing a few of those, dropping and lifting and seeing how that feels. One side is fixed, the other side is dynamically moving, especially the dropping down, to see how that feels for you to practice. And it may be, this chair for me isn't ideal, it's just one I happen to have in this room. I would probably do it on a more solid chair. Okay, and then I'm going to circle, do like I call it the big wheel. I've got one side of my pelvis fixed, the other side is moving. And don't worry if you haven't got a lot of movement, just a little bit is fine. Go around the other way and just sense how that feels until you kind of feel a little tired. And then come back to sit square in the middle again. Adjust your pelvis, fidget your bottom, try and spread those sit bones out. And notice when your head is nicely or when your pelvis is, you've got a nice wide base of support, your head is nicely balanced on top. If we maintain these sort of postures, we no wonder get a little bit humpy and sort of kyphosed. We want to try and keep moving rather than staying fixed where maybe chairs direct us to go. In fact, chairs have a lot to answer for. We are sitting too much, which I think contributes hugely to a problem. So let's come and lay down on the floor. If you are happy to lay down, then come lay down with me, and we will go on with a little bit more. So I just wanted to show you this. This is what I call a Franklin therapy ball or massage ball. They're available from Physical Company, and I use them in my Pilates class. I use partly the Franklin method in releasing tension patterns, not only around the pelvis, but also around the shoulder girdle, and they're rather delicious to use. So maybe you want to practice. There's lots of clips on YouTube that you can look at. But I have done other movement-based therapies like Feldenkrais, like Continuum, and I'll just show you the practice of this. One of my friends, when I was at her house last summer, her Labrador had found a very good use for its tennis ball and was laying on a grassy bank with the tennis ball under its back. And not only was it kind of rolling around doing self-massage, it was making happy kind of noises of kind of growly noises. And all of those things will have helped release tension patterns in the muscles that it was rolling over. And it was a dog that hadn't, been told to do that. It just intuitively followed its body instincts to kind of do it. And as humans, we often need guidance rather than use our intuition, body wisdom. And that's the kind of approach I have in my classes to try and get people to feel more, to learn more. So I'll just show you the pelvic release that I would do. And I would probably do this as part of, as part of lots of other things in a class, but it just gives you a little taster. Okay, so lay on your back, and with the ball, just place somewhere under the belly of the muscles at the back of the buttock muscle. You can roll on and off. And as we're doing this, I'm letting my knees kind of open, which is a less familiar pattern. As ladies, we tend to cross our legs or have our knees together. But rolling on and off the ball helps to release some patterns, learned patterns of movement that we've kind of acquired over the years. And as I'm squashing and unsquashing the muscles, I'm kind of bringing more blood flow, heightened awareness. And I also might find some areas that feel a little bit tender that I want to linger on for a little bit longer. So I might pause and let the breath flow. Maybe even practice that slow sniff with a flop of the belly. Feel a gentle sigh drop into the pelvic floor. So I might linger for a little bit, or I might just keep dynamically rolling on and rolling off, reposition the ball. I might even come to think, I'm just going to release here around the side of the pelvis. Maybe that feels quite nice to unstick some of those structures there. And then maybe I'm thinking, maybe the front of the pelvis feels quite nice to open, because I've been sat for a while and it's got a little bit of a sort of crease in that area of the body. And now I want to unstick and undo that crease. So I might lay and massage around the front. So many of my clients have purchased these balls, they use them at home, and they're great little tools. They only cost, I think, under £10 a ball, and they last forever. I haven't had one fail me. They can be a little bit more inflated, but I never bother. They sometimes change a little their firmness if it's cool or if it's warm. But yeah, they often provide just a soft but enough of sort of pleasure pain to sort of release tension. So I might do that. What I might also do, although some people are triggered by this or their pelvic floor muscles, if they've had a pain pattern of spasm in their muscles, this might trigger. So you'd go very carefully, but you might place a ball under your sit bone and massage around the inside edge, around the front of the sit bone. That's where your hamstrings attach, around the other areas. You just have a little play. You might lift and lower the other side. So I'm just going to come here to the side so you can see. So I've got the ball under this side, and I'd lift and lower the other side to find a little more sort of wonky length here, but I've got the floor to lean down on. Yeah, so you can kind of maybe find a little more space between those two sit bones. And then I'd always get everyone to sort of stop and take the ball away and just notice, how does each sit bone feel? One side might feel a little heightened to awareness. And I would then also perhaps get people to sense, how do the joints move near that area that you've just unstuck? So that would be the hips. And this a butterfly ring opening and closing of the knees helps us to associate and feel that the pelvis rolls forward as the knees open, and then as the knees close, we feel the pelvis tip back into that posterior tilt with the back triangle more tight. When we roll forwards, we feel a more openness generally in the whole of the pelvic floor. Yeah, that's obviously why we have babies in that position. And smear tests and so on. But yeah, it's quite nice to come into this position as a course of movement practice. Yeah, everyone's got stretchy trousers on. No one can see. Most of us are practicing maybe movement practices at home now anyway. So I might notice that the hip on the side I've released might feel a little smoother, go with a little more ease, and so on. So I've kind of unstuck some patterns of tension that might release a little more freedom of movement in some of my body. Another exercise, which is one of my favorites for releasing length into the front of the body, is this exercise, which helps to open up the deep muscle called piriformis here in the front of the and iliopsoas, the muscle in the front of the body. So what I'm just going to show you side on. So we have the feet wide apart, arms wide out to the side here. Just adjust and fidget so you feel maximally spread out on the floor. And just enjoy the floors coming up to support the back of your body as you sink into that support. And then we would let the legs gently lower to one side as the head rolls to the other, side back to the center, and swap to the other side. So this is a great exercise for bringing about a little bit more mobilization in the hip joints. And the further I might take my feet apart, or maybe bring them into my bottom a little bit towards my bottom, or I might adjust when my arms are slightly. I don't stay fixed in one place, just like when I was watching my friend's dog moving around. I didn't repeat the same thing over and over. It kept adjusting slightly and then making happy noises and kind of just playing, and because that dog wasn't thinking about so many things. Not as human beings, we think a lot rather than tune into our bodies as much as animals do. We've got boring things like I don't know, insurance quotes and things like that might preoccupy us. So we become a little too cerebral, not tuned in our bodies. So giving yourself the opportunity to do some form of maybe body-mind practice will help you to get to know the internal you a little bit better and how you can help yourself. So this side to side is also a nice one. We might soften and fold the hip up, see how it feels for you. If you've got any restriction there in the hip, maybe bring the head up. So we're unsticking that muscle we unstuck on the ball, bringing it to a more lengthened position. Release down, do the same on the other side. Fold the leg in, and notice it's feeling any different from the side that I unstuck. So I'd often unstick one side and then do a few movements, but then go ahead and unstick the other side as well. Okay, so another exercise that I love is called the yawn stretch. So you might take your legs out long. Notice when your legs are long, your back becomes a little more arched away from the floor. So if it's not comfy for you to have your legs long, obviously do bend them. They don't have to stay out long. But have your arms here crossed in front of your pelvis, and you simulate taking off a t-shirt, keeping your upper arms nice and close to your body. And you feel your belly, your ribs, everything move as the arms move, and maybe exhale to push the hands away. So we let the breath flow in as the arms elevate, lovely. And we exhale to push the heels of the hands away. Super. And make this your last one. Breathing in. And then breathing out. Spin the arms back, around and down. Great. Have a little shake out. I think I'm coming now towards the end of the time. There are, how are we going? So there are a number of movement practices. I did have a look online. There's so many different movements, and certain movements will serve certain people depending on what your imbalances are, what your problems are. So all I can encourage you to do is stay optimistic and hopeful and curious to find what your body's looking for, what your body mind is looking for to get the help you need to greater resilience, comfort, and obviously for your pelvic floor to function optimally. So thank you very much. I know many of you are joining in on the recording. Nice to see you, Katie. And I'll maybe see you again. All right, thanks very much. Oh, and I'm going to stop the screen now. Yeah, bye, Katie. Nice to see you.